and adding that into the chat. I'm Caroline Gooden. Welcome back, everybody. Good to see you all on a Thursday afternoon. I'm going to share my screen and we will get started. Dr. Sprang is with us here. All right, I see her. All right, let's see. Brandon, it's all different. All right, here we go. New computer. Are you seeing my screen accurately now?
Yes,
okay.
Looks good.
Okay. Welcome, everybody. I am Caroline Gooden and delighted to welcome you to session 7 of our Project Scope, Supporting Children of the Opioid Epidemic series. We are delighted to have Dr. Ginny Sprang with us today. She is the Executive Director of the UK Center on Trauma in Children. She has a great session planned for us. To introduce you to our team, some of you here on the call are our partners for Project Scope, which we couldn't have done this without you. Juliet Souders is here. She's our facilitator coordinator. Brandon Canova is our technology guru who will guide us today. Michaela Roark is our evaluation specialist. And many of you are our small group facilitators from the Administrative Office of the Courts and from the community. And we really appreciate each and every one of our facilitators, as well as each of you, our participants. We have 2 sessions in May for your information, and we are excited about both of them. Again, Dr. Sprang is with us today, who will be talking about provider strategies for resilience, which is something we all need when working with complicated families. And on May 19th, Dr. David Lohr will be with us talking about towards an understanding of recovery for persons with addiction. So both fascinating topics coming up for you.
So I just want to thank all of our small group facilitators. We have Caroline Gooden and Michelle Holt, myself and Leanne Kerr, Tanya Torp and Sasha Braven. And then we might have switched it a little bit, but there's Karen Cottingham and Kayla Harmon and Dr. Myra Beth Bundy and Bridget Talley, and then Andrea Whitwer and Mahela Seether for our group 6. So you will all get a chance to meet our facilitators in our small group discussion, and thank you all for being here to guide our discussions. So today's schedule, right now we're doing our welcome and our call procedures till about 4:10. Then we'll have our presentation by Dr. Sprang, and that will be around 30 minutes. And then we'll have our small group discussion breakout sessions around like 4:40, 4:45. And that will go for around 20 minutes. And then we'll come back as a large group and share back what we talked about in our discussion groups and then wrap up. So just a few reminders during this session, if you can keep your cameras on and unmute during our small group discussion so it just feels more organic, that would be great. Please enter your name, email, and county in the chat so that we have it for attendance. And also, if you need ECU TRIS credit, you can also write that in the chat. Make sure to take care of your needs during our sessions because topics can be sensitive. And also, thank you for protecting confidentiality. And when you're talking about anything in small group discussions, make sure you change the names of everyone you discuss. A reminder that addiction is a disease, not a choice. And please engage actively, both in the presentation and also in our discussions afterwards. Use person first language. So an example of this is a child born substance exposed, family with child with neonatal abstinence syndrome. This session will be recorded and closed captioning is available. You can turn it on in Zoom. Please feel free to ask questions at any time in the chat. We will read them to our presenter and we will respond. Remember to respect all viewpoints. Everything is valuable and we're happy to hear from everyone. And please, if you have any case studies for our May 19th session, please send them to myself or Caroline, and you could get a book.
Hey guys. Yeah, as always, just want to draw your attention to our Scope Echo resource page, that link there. There you can find materials such as these PowerPoint slides, recordings of past sessions, CEU information. So if anybody ever has questions about accessing that or where to find it, please send me an email. If you have any technical issues today, message me in the chat and I will do my best to help you out. Thanks for being here. Excited to have a good session.
Thank you both. So I'm going to stop sharing and introduce our guest presenter today. We are delighted to have Dr. Sprang with us. She, as you will learn, is eminently qualified to talk about this topic today. She is Executive Director of UK Centre on Trauma in Children. She's also a professor in the College of Medicine at UK in the Department of Psychiatry. She's project lead on a study that is looking at preventing child sex trafficking in middle schools. She is chair of Secondary Traumatic Stress Group. She's published widely in the area of child trauma, trauma-informed care, sexual exploitation of minors, and disaster responses, among other areas. And her work really is about creating a bridge between the research that we do and the practice that we all do in the field. So we are delighted to have Dr. Sprang with us today, and I will turn it over to you.
Thank you, Caroline. Well, I am very excited to be here with you to talk about provider strategies for resilience. And I just love this ECHO format. This is something we do at my center too. And it's just a fun, fast-paced way of interacting with material. And so I was really happy to be part of this. As we get started today, I wanted to start off by telling you a little story about Camille. And so Camille is going to be our case study for today. And Camille is a therapist at a community mental health center. And about 75% of her caseload involves treating clients who have PTSD. So she gets a big dose of indirect trauma exposure. She has high levels of stress on her job. So she has way more clients than she can deal with effectively. And there are some policies around insurance and access and equity of access that trouble her. Her colleagues are all kind of feeling similar, and they get together to support each other every week. But what she's noticed is that these sessions kind of turn into discussions about clients and their problems and the work, and they get kind of negative. And during those conversations, she finds that her exposure to traumatic material actually increases, and they're not as supportive as she would like them to be. She's also providing supervision to new clients, and this is something she loves, but lately she's finding the experience exhausting. Since the pandemic, she's noticed some changes. She's got a lot of clients that are struggling to cope with the demands of COVID, and she's been delivering services via telehealth. And she's become pretty worried about the safety and well-being of some of her child clients who are very isolated, and she feels like aren't participating well via telehealth. 3 weeks ago, a long-term client of hers died of COVID, and she's also had several family members have been ill with COVID as well. She's having some nightmares about her work, and she's having some intrusive thoughts about some of her more severe cases. She is finding that she's a little more irritable with her supervisees, her coworkers, and her family members. And she actually can't remember the last time she felt happy. She's just not enjoying things the way that she used to. So she's requesting help on what to do to address her own distress, how to build her own resilience, and how she can help her supervisees who are experiencing some of the same symptoms. So this is our case today. So but before I go on and start my presentation, are there any clarifying questions you'd like to ask about Camille? And if so, I just ask you to take yourself off mute and, or you can put those in the chat.
And there's nothing in the chat so far, Dr. Sprang.
Okay, well then I'm just going to move on and we'll have another opportunity to ask questions as we go. So the first thing I want to talk about is this phenomenon that happens when we work with other people. It's probably the reason that you all got into the field to begin with, of helping other people. And it's that empathetic engagement that can be very satisfying and can allow us to use our skills, our knowledge, and our professional self to really help create change in other people. But there is this indirect transmission of stress that happens when we work with people who have traumatic experiences, loss experiences, or living in highly stressful times.
Dr. Sprang, there's a little bit of interference sometimes with the audio. I don't think it's just me. It's kind of coming and going.
Okay.
That's better here.
Okay. I can, if it's interfering, I can try turning off my camera.
It's good.
To see.
Maybe sometimes there was some baffle on the microphone because right now it's good.
Okay. All right. So let's see how we do, but just get, interrupt me if it gets bad and I'll try turning my camera off. So this transmission happens when we hear trauma stories, when we're doing our work, when we see the suffering that trauma imposes, or we have to retell some of the graphic details of trauma to other professionals, or maybe we have to retell these stories in court. Sometimes it happens because we're seeing the manifestations of a lot of maltreatment, of trauma, of a lot of suffering in the behavior of our clients. So we see, families in distress. We see people dying. We see people self-harming because they've been sexually abused. We see people hoarding because they have been severely neglected and starved. We watch people grieve and suffer from multiple losses. And all of this causes us to carry this tremendous burden. And sometimes it weighs us down and sometimes it feels like too much, but it's also a privilege that we get to share these experiences with folks. So what we're going to talk about today is how to live into that true mission that we all want to, be part of, to help people with their suffering, to make a change in people's lives, and to keep ourselves whole and intact. And I will even say that it's an ethical mandate that we do so because our clients expect us to be well enough to help them. They come to us expecting us to be able to tolerate whatever they throw at us. And so, this is something that I want to just underscore is a normal occupational hazard. It's not a personal failing. It's not that you weren't well trained. It's that it is natural to be affected by the work we do. In fact, Naomi Remen, you probably have heard this, says the expectation that we can be immersed in suffering and loss daily and not be touched by it is as unrealistic as expecting to be able to walk through water without getting wet. And I think that what she's saying there is like, let's don't beat ourselves up about this. Let's just recognize that it's happening and find ways to build our resilience. So one of the things I'm going to be referring to as we talk today is secondary traumatic stress, because this is a threat to our resilience. And this is when we have symptoms as providers of traumatic stress that parallel PTSD. And this is actually recognized in the DSM-5 as a criterion A for PTSD. That is chronic and severe exposure during the course of one's work. And these symptoms that we have from some of these exposures that I just described are unique. It's different than burnout, which is the result of working long hours with few resources. It's also different than moral distress, which is knowing what you want to do or you should do, but there are policies or procedures or regulations that prevent you from doing the right thing. And it's even different than compassion fatigue, which is kind of a messy term that people use to kind of encompass all these things. But secondary traumatic stress is one of the biggest threats to our resilience. And these symptoms exist on a continuum. So if we looked across groups of providers, we would see there's a group of folks that will respond to these exposures and they will have no symptoms, or they will have very mild transient symptoms. That's about 15% of the provider population. And the majority of us fall into these middle categories. That is, that we have STS symptoms, but it's not impacting the way we function at home or work or in our social life. Or we do have STS symptoms and it is causing functional impairment, but we really don't meet the criteria for PTSD. There's some reasons for that I could talk to you about if you want, but then there's about 25%, between 20 and 25% of folks that will meet the criteria for PTSD. And this is due to indirect exposure. So these impacts, how long they last, whether we need treatment, really depend on many factors that confer risk on a person. And they also depend on our level of resilience. And a lot of people think that resilience means that you're unaffected by things that happen in your life. And that is actually not true. Resilience is really our capacity to recover in the face of adversity. So it's very much likened to these palm trees. When they face hurricane force winds, they lose their palm fronds. They bend with the wind. They look battered when the wind subsides, but eventually they will stand straight up. There's a lot of things about their anatomy that allow this to occur. They're flexible. Their leaves are long and pointed, so they kind of flow with the wind instead of creating a lot of resistance. And their roots are kind of very vast and broad to allow them to like bend like this. If we had, pine trees, for example, all along the coast, those would just break right off because they don't have the flexibility or these characteristics. They just have these very stiff, rigid trunks, and their roots go straight down. So the person who is resilient is like the palm tree that may be battered and may actually suffer greatly under the force of adversity, but has the capacity to stand upright once you take the exposure or the adversity away. And research tells us that highly resilient people tend to possess three common traits. And these kind of fall into these three categories. They have accurate appraisals of what's happening to them. So they're psychologically flexible. They're able to identify negative distortions and correct those. They can shift perspectives, and they have a strong sense of purpose. So these are traits that we try to cultivate in children. When we treat children to overcome adversity, we really work on their cognitive appraisals, their psychological flexibility, which I say is like a superpower that we all have. If we were all psychologically flexible, we would do so much better with change and with adversity. And then not only do they have, they feel like they can accomplish something, they're connected in a way, either to a social network, to a cause that's greater than themselves, et cetera. So these are the kinds of things that we tend to target, and we'll talk about as we talk about strategies. But I also want to make the point that it's not just an individual responsibility. You've heard all of these talks that you see out there about self-care. And I think self-care is great. It's certainly a piece of our strategy, but self-care in and of itself is not enough. There needs to also be an organizational component to anything that we do. So organizations need to build resilience in their employees. I call this a bifocal approach, so that you can take people away from the work environment and they can do all this kind of self-care. Like I always joke, like, so we're going to go home and we're going to get pedicures, eat a lot of kale, take a long bubble bath, kind of repair ourselves to go back the next day and be, completely beaten down, only to crawl home back into our tubs and, replenish. And that's no way to live. What we need is good self-care strategies, but then an organization that isn't toxic, that can also work with us to support health and wellness, so that we don't end up like this poor woman who went on vacation, got refreshed, and then burned up on reentry when she tried to come back to the workplace. So a model that I always like to talk about is this window of tolerance model, because this really helps us understand how we react as professionals to what's happening around us. So when we talk about the window of tolerance, we're really talking about, this is kind of a metaphor of those types of strategies and that state of being that's characterized by, let's see, my computer's frozen here. All right, when we're in our window of tolerance, we're in our comfort zone. We're emotionally regulated, which means that, our heart rate and our respirations are kind of in that state where we can remain calm, cool, and collected. We also feel very connected to other people. We also have this ability to self-regulate. So we're in a place where we can notice what's happening to us and we can self-regulate. And when we're in our window of tolerance, we have healthy relationships because we are calm, cool, and connected. And not only are we able to stay in touch with our own feelings, but we're really good at picking up on what's going on with other people and responding appropriately. But what can happen is that things happen during the course of our day as professionals that might move us outside of our window of tolerance. And the thing that I always talk about here is it's usually a fear state. And I don't talk about fear as in I'm fearful for my life, though some people in some positions may feel that way, but it's this lack of psychological safety that might occur where this job is not good for me. This job is a threat to my well-being and my mental health. And when we have those perceptions, we can move into a state of hyperarousal. In fact, somebody named Mary Karr said, fear can transform our experience in very profound ways. It can take that highly educated brain of ours and reduce it to the state of a dog crouched over a bone. And so when we're in this hyperaroused state, we notice that we might feel more aggressive, where we might have anger and rage, outburst. We're more impulsive in what we say and how we act. We may feel chaotic and other people may perceive us as creating chaos. There may be sleep disturbances and overeating. And all of this is because our fight, flight, or freeze state has been activated at work because we feel under siege or under threat in some way. There's also a hypoaroused state. That's another threat, something that can happen when we move outside of our window of tolerance. And in this state, we're just kind of shutting down. And you may know people like this. They don't get all hyper aroused and aggressive and impulsive. They just become numb and disconnected and they shut down And they're kind of described by their colleagues as really operating on autopilot, not present. And they are, not only do they feel disconnected inside, but they appear disconnected to other people. So they have really flat affect, and may even talk about, other kinds of states like memory loss. So the things that move us outside of this window of tolerance during the day could be high doses of indirect trauma exposure, feeling physically or psychologically unsafe, as I mentioned, repeated loss or threat of loss. So for especially healthcare providers that are seeing people die or die alone, or, under threat of death to COVID, this could be an issue. Perceived loss of control. So if we're in situations and we have no control over our schedule, what we're exposed to, what the dose is, that can move us outside the window. And high exposure to trauma reminders. So when these things are happening, our window of tolerance shrinks and our states of hyper or hypoarousal can increase. So what we're really, working towards here is understanding that when to be able to stay inside of our window of tolerance, it really does require us to use both individual and organizational strategies that are working in tandem to move us through the course of our day. So I've got a little bit of lag here with my connection, and my animations are coming slow. So let's see what happens here. So if we want to stay inside our window of tolerance, there's basically 4 strategies that I'm going to talk to you about today. The first strategy is around mindful self-awareness. So this is kind of a foundational competency in emotional intelligence. It means that we are self-aware enough and in the moment enough that we can tune in and consciously be aware of our own thoughts, our emotions, and actions, and how this is impacting our behavior and how it's affecting other people. This is an executive function skill that is really pretty impressive. Our brains are able to kind of do this observing self dialogue that, no other species can do. And when we are in touch with our mind and our body and our breath, then we're able to notice that we are beginning to move outside of our window of tolerance. And then we can take actions to get back in. And so there are a number of techniques that we can use to self-assess and respond when we start to move out of the window of tolerance. So these are things like self-regulation, deep breaths, being grateful, reflecting on what we're grateful for. There's techniques like, 3 questions where we identify what our intentions are and what's getting in the way of us kind of proceeding in the way that we want to. And the more that we use these kinds of strategies, the deep breathing, the meditation, the grounding, we begin to build up muscle memory so that when we need them, we can use these strategies. So, for example, I teach an intervention, a trauma-informed intervention called Target, which is Trauma Affect Regulation Guide for Education and Treatment. And this is for kids. And so in Target, we teach kids how to do an SOS. And so an SOS is when we slow down, we focus on an orienting thought, then we do a self-check and we think about what is our body doing, how are we feeling? And so what I have noticed teaching this to kids and teaching therapists to do this over and over, that I've developed some muscle memory. So I can kind of do an SOS pretty much any time in any space. I can be walking down the hall into a meeting that I know is going to be stressful, and I can take a minute and do an SOS and really de-escalate myself. And the more I do it, the better I get. So being able to implement these skills under duress is a really important thing, and that takes lots of practice.
Dr. Sprang, there's a question in the chat. Do you want to hear it now or at the end of your presentation?
Yeah, let's go ahead and hear it.
So Tanya says that the window of tolerance model is a new term for her. Is this something that can be connected to the spoon theory? How many spoons one has throughout the day? With lack of spoons, can it activate our window of tolerance responses?
So the window of tolerance model is really a neurobiological model that's focused on how our bodies respond to perceived threat. So if you don't have enough spoons or you're dropping your spoons, that may activate a response that could move you outside the window of tolerance. But it really is, it was kind of developed by neurobiologists to really talk about what happens when we have a stress response and our body kind of kicks into that fight, flight, or freeze, and begins to generate glucocorticoids and norepinephrine and epinephrine to prepare us for a fight. Because when that happens, our awareness of other things begins to become much more narrow. For example, our digestion slows, because when we're in a fight for our life, we don't need to eat. So, other organs and other systems begin to shut down. So that is this widening or narrowing of the window of tolerance is really a response to this neurobiological response that we have.
Thank you.
And just kind of in this mindful self-awareness, there are some strategies for screening and assessment. Organizations will ask me sometimes, how can we help with this? Should we be screening our employees? Now, I always say, if you're going to screen your employees, it needs to be anonymous and private. There's no, we're not going to, organizations should not be screening employees and making them self-disclose their own mental health symptoms. So I really like this Provider Resilience app. It's a free download on your phone. It has the ProQual, which is the professional quality of life scale embedded in it, which gives you a compassion, satisfaction, burnout, and secondary trauma score. And it scores it for you because the scoring is a little difficult, but it has all this other kind of cool stuff. It's got this vacation clock on there. It gives you tips and strategies of what you should do based on what your scores are. And if you are scoring really high, it will tell you, hey, you need to seek out some professional support and assistance because your score is high enough. At my center, we have a website too, and I'll put this in the chat at the end, where you could do some self-scoring that's all private and nobody sees it but you. The next strategy I want to talk about is, our jobs require a certain amount of transmission, interpersonal transmission of suffering and stress. But there is sometimes unnecessary indirect exposure that happens in the workplace. And not all of that is required by our jobs. So for example, if you're a therapist and you're doing TFCBT, you do a trauma narrative. That's part of your job. We're not saying don't do that. You should still do that. That's, an essential element of the intervention. If you're a child welfare worker, you're still going to do investigations and testify in court. But there are ways to reduce indirect trauma exposure based on how we talk to each other, both in supervision, in the hallway, in the lunchroom. And we call this low impact debriefing or low impact processing. And it's basically a 4-step method of reducing some of this graphic transmission that's unnecessary. So the 4 steps are like this. You start off with a lot of self-awareness. So you notice, oh my gosh, I'm moving out of my window of tolerance. I'm feeling pretty hyper aroused. I want to talk about this encounter that I just had. And so you, instead of kind of going down the hall, plopping down in a chair in your colleague's office and just like kind of, vomiting out all this stuff on them, we call that sliming. So we don't want to do that. No sliming. We say to them, hey, fair warning, I'm feeling super agitated and I just had this really difficult encounter. I've got all these things going on in my head. I want to talk about it. And then you ask for consent. You ask for consent. Is this a good time? Can I talk to you about this? Because maybe they just had their own very stressful encounter and this is not a good time for them. And then when you share graphic detail, you do limited disclosure. You only talk about the feelings and not the details. So nobody wants to hear, nor does anybody want to repeat all of those graphic details about sexual abuse you just heard, or the horrible torture that this client just described. What we do need to talk about and what we want to talk about is how does it feel to live in a world where people do that to each other? What kind of thoughts are going through your head that you're going to have to get out of your head before you're going to be able to have a good night's sleep? What it means to live in a world with this kind of stuff is happening and you're having to hear it all the time. That's what we need to talk about. So with this low impact processing, we're changing the way we talk about our work so that we're not unnecessarily sliming people. The third strategy to build resilience is really around just the self-regulation skills that we have. So we want to make sure that we know what the symptoms are of secondary traumatic stress, of burnout, of moral distress, that we've gotten enough education about these things so that we have realistic and accurate appraisals of our responses to the work that we do. We want to use breath control to downregulate our physiological symptoms of distress. We want to engage in perspective shifting so that we can get some cognitive distance from the source of stress. So if we have, research will show that people with more rigid beliefs that don't have flexibility, psychological flexibility, and aren't willing to consider other perspectives tend to have more difficulty. So resilience building really has a lot to do with kind of being psychologically nimble and being able to shift perspectives and even consider the perspectives of other people and other ways of thinking about your own symptoms. And then being aware of our affect and regulating it by naming what we're feeling, by noticing it, by processing in a very healthy way, a low impact way. Journaling is another way of processing, but we as human beings are not meant to keep things inside and never process them. So emotional processing is an important part of almost every intervention that has anything to do with trauma that you will notice, and it is important for professionals too. We just have to do it in a very healthy way. For those of you who are in formal settings where you have some supervision, that's great, because trauma-informed supervision really kind of gives you a way to engage in deliberate reflective practice, so that instead of just shaming people by doing only administrative supervision, we can take a trauma-informed and reflective approach. So I am kind of giving you some reflective prompts that supervisors might use in their work to engage in a conversation. And you don't have to have like a formal supervisor if you're doing peer support. It could be two peers. It could also be a mentor that would use this. But just asking your mentee, your peer, your supervisee questions like, what were you trying to accomplish there? How do you think you did? We're inviting reflection on the experience. And in doing so, we're inviting the creation of an observing self. What effect did this have on you? So we're not doing therapy, but we're inviting the person to consider that the work might have had some impact on them. We're asking, did you feel overwhelmed by this? And then we're accepting whatever answer they give us. So we're not pushing, we're not probing, we're just opening up a conversation. We can say, tell me more about that. If they start down the road of describing their thoughts and feelings, we can ask specific questions like, do you find yourself thinking about this person or situation at night? If you're worried about your peer, your mentee, or your supervisee, or asking a question like, what does it feel like to be in this situation? If they've just described, a very difficult encounter with a patient or a client. And then just also remembering that when we're doing reflection, that we also want to think about strengths. And so asking a question like, given who you are, what do you bring to the situation? So people can focus on their strengths, not just the ways that they may be negatively affected by the work. And then STS-informed competencies for trauma-informed supervision. I'm part of a group with the National Child Traumatic Stress Network, and we have developed 9 competencies that a supervisor would have if they're STS informed and being able to build resilience. And there's also a self-rating tool if you wanted to do a little self-assessment. And I can put the link to that as well in the chat. So I've kind of given you 4 ways to build resilience: this mindful self-awareness, reducing indirect exposures, the use of self-regulation, and then using supervision. But this could also be peer support or mentoring as well if you're not in an organization that has supervision. And then just like as a final thing, just for leaders, if you're a leader, you're on the call and you're like, either a senior leader, a CEO, a manager, program director, that old adage of put your oxygen mask on first before you help others, I think applies here. Like there is a responsibility if you're in a leadership position to try to be okay so that you can help other people be okay also. And so I know that compassion rarely flows up. So you spend a lot of your time supporting the people below you. So we just want to make sure that you don't neglect yourself and you don't take yourself out of the equation when we talk about time for resilience. So I'll just end this with maybe some questions to prompt a discussion in the breakout groups. And so the questions are just, if we reflect back to Camille, if she doesn't get help, what might happen to her? What might we expect? The next is your organization currently doing any of these things to build resilience? Integrating mindfulness, self-awareness, reducing indirect exposures, teaching or supporting self-regulation, or STS-informed supervision. And then thinking about how you might incorporate one or more of these strategies into your own work life. So I tried to give you an organizational perspective and then an individual perspective, because remember, we want those things to go together.
Dr. Sprang, that is excellent, useful information. Do you want to offer folks a chance to ask any questions, unmute and ask questions before we go into small groups? We can stop sharing the screen if you want to. Actually, let's leave it on so they can see those questions, but let's just open it up for anybody that has comments, clarifying questions before we go into small groups. We'll leave this up here for you to look at. I don't see anything coming. Go ahead. Someone have a question? Here's a question. Is there any support for Camille at her place of employment?
So she has a network of peers and they have formed an informal support network. But what's happening in those meetings, while she gets some camaraderie and support from being with them, so it's decreasing her isolation, they're sliming each other during these meetings. And so those encounters are not as helpful as they could be.
Good question. Well, we've seen that happen too.
Yes.
So I would encourage you, if you're a small group facilitator or just not, you can take a picture of these questions if you wish. They were also sent to you ahead of time. And we'll pause for any other clarifying questions. Okay. Well, Brandon will move us into small groups and